All right, we are back for our third and last part of our normal newborn recorded lecture. All right, so you guys would have watched the video about assessing the scalp and the importance of watching for caput cephalohematoma or subglial hematoma. All right. Some of the other variations we're going to look at, and we're going to go into a lot more depth of this during our synchronous part of the class, is just thinking about, assessing the newborn. You're doing your head-to-toe assessment. What are you looking for? So what are you seeing here? What is this? And you should all have said milia, right? Newborn acne. Little whiteheads. So again, it's just those immature systems of the newborn. They have a lot of plugged glands, so sebaceous glands, so they get these kind of little whiteheads. And as their neurological system and their systems mature, a lot of these will disappear. So that's just your newborn milia or newborn acne. And then what do we got here? What are you guys seeing on this newborn? This guy is covered in vernix. So that kind of cheesy cream cheese substance that protects the skin from long-term waterlogging. That's what we're seeing on this newborn, so that vernix. So in our synchronous in-class activity, we're going to go through a lot of some of these pictures and just saying, okay, what are these? And working our way through those. And so, do you know what vernix caseosa is? Do you know what lanugo is? That really fine hair, again, we see that on our more premature infants, that really fine hair, that milia, that newborn acne, mongolium spots. So that bruising that tends to be right around the coccyx, that's actually not a bruise, it's a birthmark. So if they have any darker skinned ancestry, often they tend to have more of that. And then our erythema toxicum. This is a very common finding we see on the newborn. Any ideas what that is? And it's our newborn rash. So they kind of get these little red splotchy rashes. You think they're having an allergic reaction. They're really not. It's kind of like super sensitive skin. They've come in contact with our linens, our detergents, our chemicals, our environment for the first time, and they're reacting to it. So, but this should, it comes and it goes and it moves around their body, but it should resolve. And when we're looking at the umbilical cord, what should it look like? Well, we should be assessing it for how thick is it? How thin is it? Is it nice and gelatinous? Or does it have two arteries and a vein? We don't do anything special with the care with the umbilical cords anymore. It's just air dry, clean with water and Q-tip. And then as soon as the cord is, we clamp it, but we take that clamp off before they leave the hospital, usually as soon as the cord's dry. Change in policy. We don't take the clamp off anymore. We just let it fall off with the cord when the cord falls off in about a week to 3 weeks. And watching for infections. So all these patient education things that we have to be thinking about with our families, watching for signs and symptoms of infection, when and where to get help. All right, genitalia. We know when you're looking at the newborn, that head-to-toe assessment, all of a sudden they can look a little swollen and edematous down in their private parts. And they can be darker, and our females can get a pseudomensis, which really freaks our dads out. So all of a sudden they're like, they got the call bell ringing, and dad's like, hey, I got my newborn, and she's got, they think there's blood in the diaper. So you go down there, and it's a little girl, and there's kind of heavy mucus and a few spots of blood, and then you can tell them all about pseudomensis, or fake periods that our female little girls can have. We want to check our male, obviously our genitalia for sex and that all the structures are there. And then for our males, we definitely want to check and make sure both testes are there and making sure that everything is patent. So can they pee, and are the openings all where they're supposed to be? Another thing I'm going to touch really briefly on is our microbiome. So it's really important with the newborn now. This is new research that's coming out. It's been talked about a lot over the years. We don't have a lot of really concrete research on it, but we're getting more and more, and there's a lot of movement on this. And just recognizing that our microbiome, that normal, healthy flora and bacteria that we have on our skin and in our body, and how important it is to health. So really looking at our microbiome, and we're seeing this in our pregnancy population, especially around our C-section births, where they're not being inoculated with a mom's biome through that normal natural birth process. So is there ways that we can actually inoculate them with a healthy microbiome and limit some of their exposures that will impact negatively the microbiome? So if you're breastfeeding rather than bottle feeding, a way better chance of seeding and maintaining that healthy microbiome. And we don't have solid research yet, but they're thinking there's a lot of links to really good health by having a healthy microbiome. And we want to start looking at our neuromuscular with our infants. So what's their tone? How are they holding themselves? Their normal neuromuscular positioning is flexed. They should be tightly flexed. Some transient tremors are normal, but we want to watch if they're jittery and all the time, because that could be a sign of hypoglycemia. And are we checking our reflexes, which are really fun to check, right? Who cannot resist putting your hand into the hand of a newborn and having them grasp your finger? We're checking their palmar grasp. You can actually do that on their foot, and you can check and see if their toes will grasp your finger as well. So you're checking all sorts of reflexes. And I don't know if you guys knew that there is like 17 different reflexes at the newborn that are specific to the newborn that helps them transition. And a lot of these tend to disappear as they get older. But yeah, there's lots of different reflexes so suck reflex, root reflex, grasp reflex, right? All of these reflex help them find the breast, find the nipple, and being able to get nutrients. Checking the extremities. So there's no visible arch. We don't really want to see a visible arch in the foot. We're watching for how straight the legs are and if they're inverting or exverting, if we have to do anything. Checking to see if there's any extra digits or birth injuries or limitations in range of motions. So doing that really good assessment. And of course, the physicians do the hip dysplasia checks. So they're looking for the Ortolantes click or Ortolantes test. But we should still be watching for the symmetry of the gluteal and thigh folds, looking at the hip abduction, checking to see how they look. So looking at these gluteal folds and making sure everything's symmetrical. And checking all these reflexes. So the moral reflex, which is often the startle reflex, right? So that's where you extension, deflection, and then the plantar grasp. And then are they rooting? Are they sucking? The Babinski on their feet when you check. And then do they fan? So, and you guys all know that you want to see the Babinski reflex on a newborn, but you never want to see it on an adult. That's a neurological regression, and that's not a good sign on an adult, but it's normal in the newborn. And then thinking about your newborn senses, knowing, what are the strongest senses? So how do we stimulate all these senses to optimize growth and development? And we're going to talk about that more in our synchronous class. And some of our newborn medications. So again, a review from our first day is thinking about what type of medications do we give the newborns and why are we giving them? We have to get informed consent from our family. So if you're going to give a needle to a newborn, you really need to be able to explain it to the families about why you're doing this, what it means, benefits, risks, and then get permission. So what is vitamin K and why are you giving it? Well, why do we need vitamin K? It's an essential part of the clotting cascade. We don't produce it as a newborn because the gut is still sterile. And even though it's rare that we have some kind of hemorrhagic problem or concern with a newborn, this is still a good prophylaxis so that if they do start to bleed, they can actually have the factors they need to stop the bleeding. So we give it as an injection in the muscle, and so the main side effect is just the injection irritation and some discomfort in that muscle, but really no other significant side effects. But what is the nurse forgetting in this picture? She should be wearing gloves. All right. So why do we give vitamin K in the newborn? What do you guys think? A, B, C, or D? And of course, the correct answer is we want to enhance the ability of blood to clot. Vitamin K is an essential part of the clotting cascade. You only get it through nutrition and absorption through the gut. So you got to be eating first. All right, and then what other prophylaxis do we do? Well, we do erythromycin eye ointment. So if the newborn comes in contact with any kind of active gonorrhea or chlamydia as they are born through the mom's birth canal, then they can get eye infection that can lead to blindness. So we do erythromycin eye ointment prophylactically. Can cause a little bit of irritation and swelling at the eyes and can make their vision a little blurry just initially because it's kind of a heavier ointment. But other than that, doesn't seem to have any other negative side effects. And we like to give it within 2 hours after birth. And then we want to be aware of family's preferred feeding method for infant nutrition. And then we give the family really good non-judgmental feeding support and respect their decisions. But this is an informed decision. So we want to make sure they've got all the education and information they need to make an informed decision around this and any other procedures we do with a newborn. All right. So we certainly know that we've got a whole class on breastfeeding, so we're not going to go into this at this point, but just recognizing that breastfeeding is our norm and is our optimal best way to feed our infant, but we do have options for bottle feeding as well. So with their breastfeeding, do we understand how breastfeeding works? So basically you have to have the newborn to the breast, you have to have milk removal to send the signal to the brain to say make the hormones to increase to make more milk. So you have to have milk removal in order to get milk production. All right. And when you're working with a newborn, you're going to always, every shift, you're going to assess the feed to see how good the latch is, how everybody's doing handling this, as well as good education, and then seeing is the baby getting enough milk. So if they're doing formula feeding, same thing. We got good supports, good education on how to do this safely and best practice, keeping the formula, the bottles sterile and clean, making sure the formula is mixed up properly. And the mothers have reported that they do not get sufficient information related to this from healthcare workers. So if they're breastfeeding, I don't typically give them a lot of formula feeding information. But if they know they're going to be expressing breast milk and still bottle feeding, a lot of the same principles apply. So you could just ask them if they want education on that. And then letting them know about when you would start to introduce solids. So not until 6 months of age, and then how they do it. And public health is really good with following up with this as well as their other regular appointments. But if they're not seeing their physician, this may be the only interaction they have with the healthcare system, or it might be sporadic interaction. So if we can really get a good connection, build a good rapport with them, and find out what their needs are, hopefully we can give them a good foundation and starting point. All right, with the newborn, we always have to be assessing, are they getting enough to eat, and monitoring intake, so assessing feeds, as well as output. So what kind of stools are they having? Our first meconium is very, very dark, black, sticky. And then as they get enough nutrients and start to get more fluid, then we're going to notice that their output increases. So what goes in must come out. And if they're getting enough in, then we're going to see enough coming out. So monitor pees and poops. Day 1, they've got 1 mech stool and a void. That's normal. At day 2, if they've had 2 mechs or transitioning stools with 2 voids, that's very normal. And day 3, if they're getting 6 to 8 voids, which is plenty, and they've got at least typically I say 3 to 4 palm-sized stools, but they often have more smaller ones, or they might save it up and have one massive, gigantic stool. But if they're having 4 to 5 stools, then you know it's not enough. So we also need to monitor weight. So we weigh babies initially after they're born, and they are weighed at discharge. If there's concerns in between that, there's this high risk factors or a lot of feeding issues, we might weigh them in between, but typically it's at birth and at discharge. And we know typically they are going to lose up to 7 to 10% of their weight in the first week, but they should be back up to their normal birth weight around day 14. If they're not, that's concerning, so we need to continue to follow up on that. So know that it's normal that they lose some weight initially, but then they should be back up to birth weight by day 14. Also be monitoring output in your urine to see if it's concentrated, and it should start to dilute. But normals, especially in the first 24 hours, you might see very concentrated urine, so you get the urine crystals, and then uric acid or urine crystals, as well as you might notice some pseudomensis. All right, and of course, family-centered care is essential. We have to put the family at the center of this. We need to be working with the family, not doing to the family. So involving them in the discussions, asking them what's important to them, what are their goals for, and what supports and information they would like while they're there, with balancing that with the need to know stuff that every family that's had a baby needs to know. So, you know, what to watch for, signs and symptoms of infection, if you're bleeding too much with your moms or with your babes, jaundice concerns, are they getting enough milk, proper ways to feed, right? So much education. This is an education floor, guys. We are already planning for discharge as soon as the babes are born. They're not in the hospital long. We got to be thinking about education and, more importantly, supports in the community and so they can access reliable sources of information when they're home, because they're not going to retain everything. We cannot make them experts in 24 hours after they've just had a baby. At that point, they're probably just, I want to get to know my baby and I want some sleep. And I'm sore and I'm tired. So we have to tailor our education, recognizing that, but we need to give them the resources and know that they understand where those supports are before they go home. All right, so we also need to make sure that there's good follow-up in the community, that public health is aware, that all the information has been communicated to public health, that they have a family doctor, that they have appointments booked, so that they are getting routine follow-up, because a lot can happen after they go home. We know cardiac issues can peak around a week of age. We know jaundice can peak around 3 to 5 days of age. You watch that video on subgleal hemorrhage where you may not even notice it till a week. So there's that proper follow-up in the community is extremely important. And of course, what's out there for community resources and other education. So our local Parent Link Center, do they have infant CPR? They want to take an infant CPR course. Good educational resources, online resources. So hook them up to the Healthy Parents, Healthy Children website, the AHS sites, and so they recognize signs of illness in the newborn. So we hit the highlights. We're constantly touching base on a lot of this information throughout their whole hospital stay, and then making sure they have the proper community resources. And then PURPLE is just kind of one of those acronyms and a program that has developed, but just letting people know that sometimes newborns cry for no reason, but how are you going to deal with that? And recognize that you still need to deal with a crying infant and troubleshoot that and soothe them and see what's going on. But if you have a true colicky infant, you need a lot more levels of support. So give them the education to understand what's normal crying, when it's abnormal crying, what the things they should do to troubleshoot and be checking out. So are they sick? Do they have a temperature? Are they hungry? Do they need their diaper changed? They too hot? They too cold? So kind of going through those standard, just checking in with the newborn. But if you checked all those things and everything's good, sometimes babies just cry. Should always get them followed up with a pediatrician to rule out that there isn't anything underlying. but sometimes they're just a little uncomfortable in immature systems, and they got a lot of growing pains, and some infants just cry a little more than others. So what supports do they have? How are they connected with the community? Is there somebody that can spell them off? So it's all important things to check. All right. So as we come to the end, wrapping things up, do you understand your fetal development? So when are they what happens preconception? So what should we be doing from a health education, health promotion perspective to, teaching our young child-rearing woman or child-rearing woman of child-rearing age, folic acid, good nutrition, good exercise, how to stay safe, protect yourself from sexually transmitted infections and unwanted pregnancies. But if you are wanting to get pregnant, how are we going to help support that? Knowing about those teratogens and healthy fetal development, and when are those fetuses more susceptible. We've looked at lots of newborn assessment. We talked about 3 ways a newborn differs from an adult, especially in our fetal circulation and as we change in that extrauterine life in those first few breaths. Name a screen for newborn complication. We didn't get into that. I've moved that into the activity portion, but our newborn metabolic screening, so our routine screening that we do in the hospital, and our nursing actions to support infant health, good assessments, good data collection, and then just understanding normal newborn and the physiology behind normal newborn and when there can be complications. All right. Thanks, guys, and I will see you on Wednesday morning at 11 for our synchronous portion. Take care.